Let me kick this off. This is John Monahan. Welcome to Conversations in Health, Global to Local. This is our first class with an outside speaker this semester. And as I told you in our first week, we always are flexible. So we had to adjust to the storm and our new and being online. But everybody on this call has lived through online education, so this will not be a surprise. And let me just say again tonight, we have a fabulous first guest, Dr. Shannon Hayter, who's most recently was the Dean of the School of International Service at the American University, just a couple miles away, and has had an amazing career, which you'll hear about. But everything from working at UNAIDS to CDC to working in the District of Columbia Department of Public Health, being a candidate for Congress, and many other things. So it will be a fabulous evening. Dr. Hayter has had a truly remarkable career of achievement at really every level, local, national, global. And we're really lucky to have her kick us off this semester. So with that, I think unless there are any questions, I think we'll just get started. We'll probably take about 20, 30 minutes and then we'll turn it over to questions. But uh Shannon, Dr. Hayter, we have known each other for quite a few years, but I do want to start off with just I always like to start at the beginning because we will get into some amazing roles that you've played in public health. But could you tell us a little bit about where it all started? Where did you grow up? And just a little bit of your path, and then we can go from there.
Sure. Well, excited to be here. Please call me
Excellent.
Shannon, everyone. So thanks for having me tonight. Yeah, I am from a small town, used to be a much smaller town. Now it's only smallish, I guess, outside of Seattle. And I grew up on my great-grandfather's old farm property kind of thing. And sort of lived on the same property our entire lives. And uh, gosh, what do you want to know? I went off, I'll jump,
Siblings,
yeah,
siblings, parent.
older brother, older sister. So I'm
Oh,
the
gotcha.
baby.
Okay.
I have really amazing parents who I think grew up both with a real appreciation of education and a thirst for sort of travel and exploration and adventure. But neither one of them had the kind of sort of family support to go off and get a 4-year college degree that they were able to give me that opportunity for. So I couldn't, I was always usually sort of the youngest one in my class, and I just couldn't wait to blow my small town and get out of there and start
Right.
exploring the world kind of thing. Yeah.
And so you grew up, I mean, you said a farm.
Mhm.
Was it a working farm when you were growing up with your?
Mostly no, mostly just hay. So we did hay in
Okay.
the summers, but other than that, just lots of cats and barn cats too. Cats.
Oh,
This
I
is
should
actually
say,
alive in the
I
back
guess,
here.
I guess we should note that this, again, we're another first year for our classes. We have at least two cats. So who is right behind you now?
This is Coda.
Excellent, excellent.
Yeah.
So there's another cat who may join us at some point too. Oh, here we go.
She's asleep in the dish there, so.
So, well, let me ask, so when you were growing up, I mean, I obviously you moved on to become a medical doctor and a public health career. Did you have an interest when you were in school in science in particular, or is that something that came later in your career? How did you
Yeah,
decide?
no, I think I grew up always sort of interested in science and medicine and maybe not so atypical these days, but first I wanted to be a marine biologist because I am from the Pacific Northwest and we have
Right.
amazing, marine biology up
Right.
there and things like that. I think I have my, little orca mug here.
Right.
Then I wanted to be a veterinarian for marine mammals, and then I
Mhm.
think as I got a little older, I thought, well, people are okay. I could do the doctor thing.
Gotcha. Got it. Fair enough. Fair enough. So smaller town outside of Seattle. And then how did you, so I guess maybe take us to where closer to
Yeah.
where our students are. Where did you end up going to college, and
Yeah.
what were you thinking? What you? It sounds like you were the first in your family, first generation in your family at least, who had the
Yeah,
opportunity
first
to go.
generation to get a 4-year degree.
Oh,
So,
awesome.
back in the day, we didn't have the Common App. We had these actual physical books called Barron's Handbook of Colleges that you could like look through and start to look at colleges. And then after you took the, National Merit Scholarship test, you'd start getting inundated with brochures from different things. So, I graduated when I was 16, and I ended up
Wow.
going off to Stanford for undergraduate, never having visited or stepped foot on the campus until I arrived my freshman year, kind of thing. Yeah.
I mean, obviously you got a lot done to graduate when you were 16. So did you just accelerate through, or was it something that you decided you really were ready to leave?
No,
Okay.
I have a summer birthday, so I was always on the younger side, and then I skipped eighth grade. So
Gotcha. Okay,
yeah,
so you were ready to roll. Okay.
I was
Yeah,
ready to roll.
Stanford is a pretty amazing place to find yourself. So what was that like transitioning from where you'd been to Stanford's campus?
It was great, actually. I call it the happy place. So,
Oh.
and we don't have snowstorms there, by the way. So, didn't have
Yes,
to
the
worry
weather is
about that.
perfect there pretty much all the
Yeah, yeah. No, I think I was really lucky to have landed there. And of course, still huge amounts of my really good friends from my college times. But I think importantly too, there was certainly an ethos or a culture that was about not having to follow a certain track, that
time.
was really about, you're going to be just fine. Like work hard, learn everything you can, and you'll be able to make choices along the way to decide what you want to do. That was really good.
And did you, because this is what
Yeah.
most of our colleagues here are undergrads, did you have, what was your major and how did you decide that when you were,
Yeah. So I majored in biological sciences and did pre-med, but also I did sort of the equivalent of a minor in international relations at the time. I think when I went off to school, I thought maybe I wanted to be a medical doctor, but all I knew about, being a doctor was the pediatrician who gave shots in the office 9 to 5, and I couldn't see myself doing that. And at the same time, I was interested in the bigger world, and, travel and culture and politics and communities and inequalities and human rights and things like that. Yeah, so that's where I started. And I ended up, I stopped out of school after my sophomore year, which is something we did back then, like a gap year, but
in the
something I
middle,
stopped
right?
out
Yep, yep.
from. Yeah, and I moved to Taiwan and I lived and worked and studied in Taiwan for the year, and got to travel around mainland China over
Wow.
the summer before I came back. And that's sort of where I discovered that, and coming back to school, discovered public health. Sort of had some
Interesting.
aha movements then. Yeah.
Could you mind sharing at least one of them, maybe from either China
Yeah.
or from Taiwan, where
Yeah.
both of which would have fascinating public health,
Oh, it
especially in
was,
that era.
yeah. I mean, it was an amazing year. I landed in Taiwan 2 weeks after martial law had been lifted for the first time in 40 years, because when Chiang Kai-shek fled the mainland with the elected senators, they, took over Taiwan and made that the seat of the government. I was there. It was a very political active year. It was the year that Chiang Kai-shek's son, Jiang Jingguo, who had been the next president, died, and the first Taiwanese-born president was appointed. It was a time when they were getting into sort of fistfights in Congress or Parliament. There was the legalization of political opposition parties and nightclubs for young people, because apparently those things go hand in hand in the evolution of democracy. So that was all happening, sort of validating that sort of interest and curiosity in the big
Right.
picture politics and society and change and culture. And at the same time, I was spending some of my time volunteering at an orphanage. And it was an orphanage that specialized in kids who had various physical disabilities. I've never gone back and validated this story, but this is the story I heard at the time, so it's part of my narrative,
Sure.
true or not. And these were kids that were sort of at a teenage, early teenage years. And there's one kid I worked with who had really, really severe, debilitating scoliosis, curvature of the spine, and
Right.
needed to ambulate with crutches and things like that. And the story I heard was, in fact, he had been refused surgical correction of his scoliosis because he had hepatitis B. And hepatitis B was endemic or, very generalized, particularly in Asia, but particularly in Taiwan, small island, can be passed mother to baby. And if the babies get it, you might have been following some of this in the news with the vaccinations lately. But if the babies are exposed inter-utero, they have a really high likelihood of going on and getting active disease from the hepatitis. And he and some of the other children at the orphanage were, as I heard it, part of a generation that had been supposed to have been born hepatitis B free because there had been a partnership with the University of Washington, which had helped develop the new hepatitis B vaccine that is all proven to, be safe and effective. And there had been a partnership with UW and either the local university, Ministry of Health in Taiwan, that, hey, proof of concept, this is a small island, high rate of disease, but if we vaccinate every single baby born, we can interrupt the whole generation's transmission. And right before that implementation was supposed to start is when the US changed its recognition politically from Taiwan to mainland China. And the
Yeah.
political trust was so broken that that partnership just got canceled. And so that was my first introduction of public health because, of course, the big P politics of bilateral relationships had nothing to do with that orphanage, nothing to do with health at all. And yet I was staring in the face of all these children whose health had been affected for life based on these huge geopolitical forces that had nothing to do with their hepatitis, right? And so
Wow.
then I went back to school, and my very first dorm talk of the year, that would have been my junior year then, was from this bright young pediatric infectious disease attending who had just finished her 2 years as a virus hunter at the Centers for Disease Control and Prevention and was now doing research in viral diarrhea in daycare centers in Palo Alto and Mexico City. I was like, oh, if that's what a doctor does, I can do that. So made sense to me finally.
So, so you had that experience and you
Yeah.
decided to go to medical school. So where did you end up going
Mhm.
to medical school? Did you go right away after college?
I took one more year off and I went back to Taiwan for a while, worked for a bit, and then traveled in Europe a little bit. But I went to Columbia in New York City, and mostly because at the time, I knew I was going to med school to also do public health, and I could
Yeah.
do my MPH at the same time as my MD back in the day without any extra time, just by taking more classes at night and spending that first summer in classes, and also because they had a global health rotation and a physician and
Yeah.
human rights rotation. So those two things are what drew me to Columbia. Yeah.
So med school, so MD, MPH from
hmm
Columbia, and then so where did you do your residency and start off in your doctor life?
Yeah. Well, my last 3 months of medical school, I did my tropical medicine rotation in Zimbabwe, by the way.
Oh,
So
wow.
worked with Mary Bassett, who's
Yeah.
now well known in public health here, but this is during her Zimbabwe years. And then for my residencies, I decided to do a combined internal medicine and pediatrics residency, sort of like a double residency on a shorter time frame. So I went, there were only a handful of those programs at the time. And I went to Duke because back in the day when we didn't have a lot of these regulations, Duke had both a fantastic med peds program, one of the first in the country, but they also had a really strong global health program. So I was able to spend about 9 months of my 4 years working overseas as part of my training during that time.
Wow. And so where did
Yeah.
where were you overseas during that?
For internal medicine, I did a rotation in Brazil for infectious diseases, and which was incredible. In this city called a city that's almost like a little. Oh, we've got a Brazilian here, so a little bit north on the coast there, but not very far north. And then I spent another 3 months in Beijing at Beijing EUN, Beijing Number One Hospital in their critical care and pulmonary unit.
Okay.
And then I spent time in Jamaica working at their sickle cell clinic there. They're one of the top sickle cell clinics in the world. with the University of the West Indies, and I spent some time, where's the first place? Oh, in Xinjiang, China, which is way out west in the Taklamakan Desert, furthest place in the world from the sea. And so they had a huge problem with iodine deficiency and cretinism. And I was part of a public health intervention there for combating iodine deficiency. Yeah.
So just so everyone knows, I didn't know most of this. I know a lot. I know some of the things we're coming to, but that's so maybe just to transition. So you've now had this terrific experience as a both in medical school and in residency. You've had a chance, a really fascinating chance to mix both global and U.S. based work.
Mm.
And so what was the next step? Was it CDC or what came next?
Yeah, it was CDC. And I
Yeah.
should just
So the
add one.
dream came true.
Absolutely. Then I finally got to go and be that virus hunter that I'd heard about from, my junior year in college that put me on this track. But I would also mention, I think, all the way through by this point, by the point I was entering CDC, I already considered myself an HIV doc or an AIDS doc, and I think, I'll date myself a lot here, but having gone to, with the interest I already expressed, having gone to college in the Bay Area in the late 80s and med school in New York City in the early 90s, and caring about both medicine and, social structure and justice and community. I don't know how I couldn't have been an AIDS
Right.
doc kind of thing. Yeah.
Well, I've found over the years it's important, since I'm older than you are, but having been in college here at Georgetown in the early 80s,
Mhm.
it's hard, and thankfully it's not something we have to remember, I mean, the experience any longer, but the
Yeah.
period where everyone you knew who was HIV positive died, like literally everyone I'd ever met. And I can't imagine, and for the physicians like you who worked in this space, it must have been, it's a searing experience. At least that's the
Yeah.
sense it must have been hard.
Yeah, I mean, I was probably on the almost optimistic generation, but not quite. So,
Mm,
when I was finishing up med school, there still was no highly effective treatment. There was
mm.
AZT,
Yep.
AZT monotherapy, which ended up failing. But by the time I got to residency and I added a pediatric and adult HIV clinic to my regular clinics throughout my 4 years. They also gave me the flexibility to do that so I could specialize as well as do the generalized stuff. And that was really the beginning of highly effective treatment and
With a
therapy.
combination, yeah.
Yeah.
Wow, so you're at CDC, and so
Mhm.
did you do the EIS? Did you do the
I did. I did
you want to tell
EIS.
folks what that's
Yeah.
about?
So the Virus Hunters or the Epidemic Intelligence Service, it's a 2 year sort of practical, on the ground epidemiology training program, applied epidemiology training program, where you're part of CDC. And you go to EIS conference a couple of months before you start, where they have, it's almost like a sorority fraternity rush, where they have a list of like, here are the 70 positions open, and here are the 70 incoming officers, and you have to run around and meet the people who are supervising the positions you might be interested in, and they range all over. About half of them are in state and local health departments, and about half of them are in Atlanta headquarters over various topics. And I went thinking I wanted to go to a state and local health department because I like getting my hands dirty and just sort of being at the front. And during that whole sort of recruitment week, the folks that were running the Division of HIV/AIDS Prevention at CDC, at that point, John, it was run by Dr. Kevin DeKalb, who is
Oh,
this
that's
huge legend,
right.
giant in the HIV field, whose papers I had read all through medical school and residency, everything from Kenya to Cote d'Ivoire to, all over the world. And to have Kevin DeKalb being like, come on, Shannon, aren't you going to come work with us here in Atlanta? Yes, yes, I am. So I ended up staying in Atlanta for that. Yeah.
Kevin is a truly towering figure in this
Yeah.
space. So it's great. And so how long did you end up staying at CDC?
Yeah, I ended up staying. 8 or 9 years, that first stint. I was a Commissioned Corps officer of the U.S. Public Health Service. I did my 2 years of EIS and then stayed on with the same department that I had done my EIS in, the Division of HIV Epidemiology. And I finished up my Clinical Infectious Disease Fellowship at the same time. So I did about 50-50 CDC and MRE infectious diseases. And then after that, it was right as PEPFAR was being announced. It was right on the tails of something that had been started under the Clinton administration called the LIFE Initiative,
Yeah.
Leadership in Fighting the Epidemic. And for the first time, CDC was allowed to and funded to open HIV program offices around the world, especially in Africa, in highly affected countries, not just research field stations. And so after my first 4 years, two EIS and two half-time, I was able to move with CDC to Zimbabwe and become the CDC Zimbabwe director. And it was a really phenomenal time. I think, first of all, it was a brand new office. It had been opened just 3 years before as the first office set up specifically to address HIV in collaboration with the ministry and programmatic rollout, not just research.
So this is about 2001, 2002.
2003.
Okay, so this is at
Um,
the right at the start of PEPFAR.
Right at the start, except we were a non-focused country. So what was happening in Zimbabwe at the time is we were labeled an outpost of tyranny by George W. Bush because of Mugabe had gotten a little dictatorial, yeah. And it was a time when there were major political, economic, and humanitarian crises going on, all stemming from the political crises. But, 1,000% daily inflation with no dollarization, both HIV in terms of humanitarian crises, where over 25% of adults were already living with HIV at the time, most of them undiagnosed and with zero treatment. But I think because it was such chaotic would be the wrong term, but it was not considered a setting set up for success is
Right.
probably why I got to be CDC director because I was 10 or 15 years younger than any of the youngest, global AIDS directors at the time. So,
Wow.
yeah.
What a great,
We,
what an amazing time and place to be. And certainly a place where you saw the intersection of politics and public health.
oh, 100%. And also, there's nothing like building relationships by sort of, you know, being and encountering both need, it was to roll out HIV treatment for the first time and learn more, have more data to focus all those efforts. Um, but to really build partnerships at a time of difficulties as well, right? And I think working together to support the Ministry of Health and with faith-based organizations that also make up a lot of the healthcare system there. Think collectively, during the 3 years I was there, Zim was able to go from fewer than 400 people in the country on life-saving HIV treatment at one small Italian rural mission hospital that was packing in drugs in suitcases to treat people, to 40,000 by the time I left 3 years later. That doubled to 80,000 the next year and is way over 1 million and has stayed that, for years now. So it was very fulfilling time, even under hardship. Yeah.
That's awesome. And then, so after the CDC years, what
Mhm.
happened next?
Yeah, so when I was coming back, well, I was still with CDC and I was
Right.
coming back stateside, and I asked to be stationed in Washington, D.C. instead of Atlanta.
Okay.
And that's like, again, I was Commissioned Corps of the U.S. Public Health Service, so I thought I would be there for 20 years because that's what retirement is 20 years or nothing, just like the other uniformed services and sort of what people did. They would join and move
Could you
around
say a
jobs within
sentence about the
CDC.
uniform? Could you say a sentence
Yeah.
about the Commission Corps? Because not everyone may be aware of.
Most people don't know about the Commission Corps, actually. So we do have two uniformed services that are not armed services in this country, one of which is the Commission Corps of the U.S. Public Health Service. I think the other is NOAA, National Oceanic Association. But just has all the same rules as, Army, Navy, Air Force, Marines, but it's an unarmed civil service or uniform service. And it's things are a little bit tipsy-turvy these days. But because it's based on the same sort of uniform services approach, you can, and many of the Commission Corps officers are at CDC, HRSA, NIH, so other HHS, they're almost all within HHS and the Indian Health Service in terms of everything from clinical to public health to research, epidemiology includes doctors, yes, but also nurses, also veterinarians, also PhD epidemiologists and others. So I came back thinking, oh,
Ex
I thought I'd be with CDC 20 years in some capacity. And at that point, I sort of felt like, well, out of sight, out of mind in Atlanta isn't really doing much for CDC. And if I'm going to be there 20 years, someone at CDC should understand how Washington, D.C. and politics work vis-a-vis public health, which was my reason for asking to be, deployed back here instead of Atlanta. And so I ended up being detailed to the State Department as the senior scientific advisor for PEPFAR at that point, the global HIV program. And after about a year, I was like, DC's sort of cute. I sort of like DC, sort of, And I did what any sort of dorky AIDS doc does at midnight on a Friday night and started Googling what's going on with AIDS in DC and found out it was actually a pretty big disaster at the time. Um, and, by 1 a.m., I was like, looks like the health commissioner under this brand new mayor who's getting all this attention, that was Mayor Adrian Fenty at the time.
Yep.
Looks like the health commissioner is also acting as the HIV/AIDS administrator. Looks like, the emails are name.name@dc.gov. So I just sent the health commissioner a note at 1 a.m. with my CV. Says, looks like you're doing some really interesting things for HIV in DC. Let me know if any, leadership jobs open up. And within 3 weeks,
Good
I
for
was
you.
quitting the feds, leaving my entire, retirement behind, and became a political appointee of the mayor to run the HIV/AIDS Hepatitis STD administration here in DC.
Wow. And so did you stay throughout the entire Fenty administration?
I stayed until June of his last year. So I stayed a little bit, about 3.5 years. Where again, I think I had been the 22nd or 23rd acting or permanent director at the time for the HIV/AIDS administration in DC. DC had a phenomenal set of community providers, community leaders, NGOs, AIDS service organizations, but the government had really been the weak link in even
Right.
getting money out the door.
Oh,
We, hadn't put out any AIDS data in 5 years and no HIV data ever. So people's impressions of what the epidemic were grounded in like 1980s, 90s kind of profiles. So, we were able to sort of turn around the data systems, get data out and evidence out, and ended up, showing that there was a really large HIV epidemic here in the nation's capital. We're able to increase diagnosis 50%, decrease mortality 30%,
it's
eliminate
incredible.
perinatal transmission, get the first ever DC funded needle exchange and comprehensive harm reduction program, set up with, 200,000 needles off the street the very first year. So having done that and built it to continue to deliver, my job was sort of done. Yeah.
So you've worked in Africa, you've worked at the CDC, you've worked very local. So where was the next exciting trip, next stop on the journey?
Yeah. So when I left that, I looked around and I went to an organization called Futures Group. It's now called
Mhm.
Palladium,
Right.
which is essentially, I mean, you could call it a Beltway bandit, but it was a global health technical assistance and consulting organization, essentially. And so I went there and ran our Center for Health Systems and Solutions, which included everything from monitoring and evaluation, implementation science. How do we work with partners to get the data they need to change their public health programs and interventions, to public-private partnerships for health, to are all of our electronic health records and tech solutions for global health. Those were sort of in my remit.
And I mean, those organizations have scaled back, but there's still work like that out there. So just for the, and then I can't remember. Is it UNAIDS next? What's,
No, I
oh,
took a year of my futures time and I did a Robert Wood Johnson Health
that's,
Policy Fellowship.
yeah,
So I finally, thanks to Robert Wood Johnson Foundation, spent a year on the Hill. So I got to do
that's right.
part of what I had come to
Yeah,
DC to do
yeah,
and learn how Congress worked. Knew how local DC government worked at that point,
right.
but learned how Congress works. So I spent the year on the Hill as a health policy fellow for Senator Ed Markey, his first year as a senator after like 37 years in the House. So it was a really fun sort of transition time, and that was during the Obamacare battles.
Yep. Oh, that's right. And okay. So those fellowships are terrific, but you were there at the right time for sure.
I was there during the 52 votes to repeal year.
Yeah.
Yeah.
I remember. I remember. And then next
Yeah.
stop on the journey?
Next stop, I went back to CDC
That's
as a civil servant this time to run the Division of
right.
Global HIV and TB, which is essentially the CDC's part of the PEPFAR program. So, $2.4 billion a year, 2,000 staff across about 40 countries at that point. So got to then sort of lead the CDC component for what I had been part of in the field for Zimbabwe. And then as an implementing partner for Futures Group too, some of that.
You were an amazing leader at CDC. That was a transitional time, certainly for the program.
Thank you.
And then next would be, was it next? I'm losing track of the sequence of all of these.
So next, because um, gosh, so that was the end of the Obama
Yes.
administration into Trump 1.0.
Yep.
And by about September, I'd made a 3-year commitment when I took the job, which was October 1st or something for me. But sort of 9 months into the administration, I I was not happy with what a lot of the global policy issues in the country were looking like. I saw a lot of things happening internally at the agency that were very insidious, but difficult to deal with in terms of blocking our ability to get money out of the door for our HIV programs that had been appropriated by Congress for that process is. But it was much more insidious. It wasn't systematic like it maybe we've seen recently, by the way. But I was also just a little heartbroken because my people in my hometown area, life was really hard for people who work hard every day, and I think it still is. And my hometown is in a purple congressional district, and the longstanding Republican congressperson decided not to run for re-election, so I quit the feds and moved home to run for Congress in Washington
So
State.
I so admire that decision. Many people come to Washington to talk about, to contribute, which is awesome, and think about how they could influence Congress, but to actually throw your hat in the ring. I know it didn't work out. And then you came back. Then what was the next step?
Then UNAIDS.
Then
Yeah,
you made, right?
yeah.
And then you were
So,
there as
mhm.
the deputy, right? To
Yeah, I was the deputy director of program, so one of the two deputy directors for UNAIDS, and at the rank of Assistant Secretary General for the United Nations in Geneva. And UNAIDS had been coming out of a bit of a scandal, and so two things that had been coming out of a sexual harassment scandal that it did not weather very well at all, and also just the long-term executive director was on schedule to complete 10 years, so we knew there was going to be a transition of the executive director. So I really went to help stabilize and reboost, reestablish UNAIDS coming out of that scandal and to help chauffeur in the transition to whoever was going to be the next executive director. Yeah.
so and
And
then
then COVID happened.
we can, right? We can talk about and then you eventually ended up here at AU, if I'm not mistaken.
Yeah, and so when I finished up my time at in Geneva and with UNAIDS, I again was casting a wide net for just opportunities that were compelling and mission driven, and happened to be that AU was looking for a dean for its School of International Service, so it's Foreign Policy School. And, I'd always worked with academics. I'd never been inside academia. Similarly to, I had always worked with the United
Right.
Nations, but I'd never been inside the United Nations. And I actually really like moving around between different types of organizations to understand the role and the position and how do you have impact from what that sort of mandate is. And so it was an exciting time to join academia. Yeah.
Well, I'll say this to our students. Shannon's one of the few people I know where we count the number of jobs we've had in the dozens. So, but what an amazing career! And I gotta just give a heads up here to Charles. I'll be looking to you in a minute, but I'm gonna ask to get us started with questions. But I can't resist asking you to reflect for a moment on how you feel the last year has impacted the response, the response to HIV, both at the local level in our community, our country, and then globally. I know it's a lot to ask, but just sort of reflections. This has been a period of extraordinary change,
Yeah.
and just sort of some thoughts as we transition to the question section.
Sure. I have many different thoughts
Sure.
on this, and I think we could talk for hours upon hours on this topic. Everything from certainly this past year has been a real shock to the system, with so many things being dismantled and paused, if not stopped. And whether it's systems or organizations or people, I would start with, whether it's PEPFAR or USAID or domestic public health. I would say always room for improvement. There is nothing about any of these systems or organizations that are ever perfect,
Right.
period. So I'm not here to defend the perfection or something like that, but I think the shock and the rapidity and really the chaos with which much has been shut down or dismantled has been difficult. It's been difficult. I think how it has impacted actual services to individuals on the ground in countries we have longstanding partnerships with has been devastating. Not as devastating sometimes as you might guess from some of the headlines, but people have died and people are still dying because of lack of services and rapid interruption of many of those services and programs not planned for. And at the same time, and John, you and I have talked about this a little bit, we are where we are.
Right.
And I think for me, as much as we have to sort of create a spot for global health or global HIV or domestic public health, even to grieve a little bit and to recognize some of the real stress, if not toxicity, that many people are under and are still under. My friends and colleagues at CDC every couple of months will get you're fired, you're not fired. This last week, all of the local health departments got all of your national grants are canceled. Oh no, they're not. So this is what the instability is a challenge in itself. But I think we have to create a space for that, but also create a space to say, and what's next?
Yeah.
If everything's sort of been, clear cut a little bit, we don't need to build or rebuild to look like the past. We should be really thinking about and designing, what's needed as we go forward. What's needed in a new way, what's needed with new tools, and then how do we make sure, this is, I think, where everybody in the audience here in the class comes to play. The future doesn't need to look like the past, but there's a lot of really great things we can do in the future if we choose to, if we design it, if we work towards it, if we try things out that indeed will have the opportunity not just to save lives, but to save more lives and to save, lives of people who were left behind before. So it might take us a while to get there. But I think I hope that we're not restricted in just what we've known in the past, and we can really think fluidly about what we want to do in the future.
Very well said. And as you said, we've discussed this. I really do think I agree with you that even if we wanted to go back to the past, I'm not sure what we should. What we need to do is think about what's a better future. And so that's a perfect transition. So I was going to ask Charles if he would kick us off with the questions. Well, I'll ask Charles, Michaela, and Becca to kick us off, and then we'll open it up to other students in the class. So, Charles, you want to get us started?
Absolutely. Thank you so much. That was super interesting. And so my first question is kind of related to your last point. So how should future health leaders engage politically without compromising scientific credibility? It's kind of a loaded question, but
Yeah, no, I mean, it's a really good question, and it made me think that I wish I had a really simple answer to it. I mean, I'll work on a simpler answer, but I think multifaceted. First of all, just asking the question is important, right? I think I'll also make a bit of a point for my personal point of view is in the clinical healthcare setting. So anyone who's doing clinical healthcare, whether it's nursing or doctor or PA or anything like that, I don't believe that sort of politics and issues belong in the exam room. I think it's really important that any patient who walks through your door, it's about them when they come through and their health and things like that. So like switching over to, the public health or the policy or the politics side of things. Let's talk about that side. I differentiate a lot between, I guess what you would say, the small p politics and the big P politics. So to me, in my mind, the small p politics includes everything that is policy oriented and making policy progress, as opposed to big P politics is that with the partisanship, right? So right now, I figure in our polarized country, we're equating a lot partisanship with political. They're actually two elements, in a sense. And so you can really think about where you want to play and how you play in those different fields, I think. And you don't have to pick just one, but to be aware of what it is. And I bring that up because I think for public health, very strong believer for public health, it's been a nice, easy slogan, especially since COVID, that, public health is about science. It's not about politics. We need to take the politics out of public health. Public health has always been about politics. That's the public in public health. It is community priorities. It is stakeholder belief and trust. And so, but it's what it hasn't always been about is big P partisanship, right? And I think that's the toxicity that's coming in. So I know I'm giving a bit of a scattered on-ramp here, but I think also necessarily if you're going to engage on changing the health of groups and communities, of populations, not just individuals, you can't do that well if you're not willing to build some of the skills or awareness of what is the community structure? What are the community needs? Where do they have community voice? Who represents them? Who doesn't? How do you get that information? And I think that to me is the real on ramp to what many of you are studying, which is on the policy side of things and the issues politics of, how do we not only know what might work and what's the evidence for that, but what does it take to influence getting that done? And I think for me, and I'll get into the big P side since I did, run for Congress as well. For me, it's really important that whatever I am advocating for or policies I'm trying to change or implement or get buy-in for, it's really important to me that they're going to work to change lives, that there's evidence or there's a way you can evaluate them and see, did it work after all? And if not, how do we change it up and try something else? So for me, part of the credibility or integrity is having a dedication to, I'm going to fight for what works, what might work, or try what works, but I'm also going to fight for the accountability that says if it doesn't work, we're going to change the game and move to something else that does. I think on the big P partisan participation, for me, they're not completely unlinked. I happen to believe that we get better, more long-lasting solutions when there is bipartisan work on an issue. Unfortunately, we're not in a time where a lot of that's happening as much anymore, but that doesn't mean I believe that it can't happen. But I think particularly for me, I don't throw out solutions just to win popularity points. I don't throw out phrases in a partisan way just to win popularity points or followers or things like that. And that might sound simple, but it's really not. I think even when I ran, which was the 2018 midterms, and we're so much more charged now than 2018, there electoral politics, people love charged up rhetoric. It was the precedent to what we now see and how you get so many, responses on social media or things like that. Biggest phrase in 2018 was being the adult in the room. I think that's an insulting comment. I don't use that either for my colleagues or my opponents. So I think there's a little bit in how you carry yourself. But I should say, I think, and John, you might have some thoughts on this too. Many people in public health, particularly not those who do health policy for healthcare, but the non-healthcare policy folks have traditionally avoided touching anything political. So I became radioactive to many long-time friends and colleagues when I decided to run for Congress. It terrified them.
Right.
We're a little bit further beyond that now. We're seeing a surge in doctors and nurses
Yeah.
running for elected office, and I think that is fantastic. But that's really just over the last maybe 7 years. So you also
As
have to
you
take that into account.
as you might recall, when you decided to throw your hat in the ring, even before I think you announced, we chatted.
That's right.
As everybody else here knows, because they've listened to my story, believe I've spent most of my life in and out of political political campaigns, partisan politics. It's not. I don't like a lot of the things that are there, but I do believe that if you see the ground of partisan politics and running for office just to the people who want to do
Enjoy
it
it.
and are willing to do it, then we've lost a lot. I
Yeah.
think doctors, nurses, people who of all walks of life, but I do think especially doctors and nurses and public health professionals see a side of human life that's really powerful, and their voices can be really effective. So I was so thrilled you ran. The voters aren't always right, but I was happy that that worked out. But let me switch, Michaela.
Yes, hi, Dr. Hayter. I was really interested in hearing about your time at specifically DC Department of Health. My eyes went wide when you mentioned emailing um, at the time. And so I was wondering how your time in the DC Department of Health working on HIV/AIDS and tuberculosis shaped your later global health CDC work on the same topic. So like
Mhm.
broad scale, bringing local public health experience to very much the global health level.
Mhm. Thank you for that question. I love that question. And believe it or not, I'm going to probably shock you in how I reverse the answer. Actually, what I did is I brought the lessons from global health back to DC local government. So I brought what we had been doing at scale in Zimbabwe to the ways we needed to turn around the epidemic here in DC, which people don't like to hear. So I don't say it in public in other big, huge rooms because we still have public who this idea that they're learning from the rest of the world, much less Africa. How dare you? Pretty crazy. But frankly, there are a lot of things that we have been doing quickly at scale, boldly, and with innovation that, yes, we're grounded in many premises of the HIV response that started more here, but had been recently taken to scale to unstick things in Zimbabwe. So things that came from the early HIV response, including in the US and including, in other countries had to do with grounding in community voice and leadership and activism, right? So the sort of nothing about us without us has been the Denver Principles. If you want to Google that, that's a really important sort of historical part of our movement and response. So grounded in all these things that have also gone global, but frankly, DC was behind. It was behind all of the other jurisdictions in the United States, by the way. Like, and at the time, I sort of said jokingly, not jokingly, it takes a true democracy to have your nation's capital have the absolute worst HIV response in the country, because dictators would just clean that up. Having just lived with a dictator, right, Mugabe. But it was also just really grounded in outdated um, programs and processes and concepts of scale. So what did we take from the global response and what PEPFAR was investing in that we invested in back here? Data, 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 not data for reporting to CDC so that you got your grants coming in, although that matters too, but data that could be broken down. And we broke it down towards. This was not something that CDC needed. We broke down our data towards and we translated it to that. What does that mean for how many people and whether or not they know they have HIV and whether or not they know about services? So we made a very evidence-based and data-based approach, which is something that was part and parcel of PEPFAR. We rolled out rapid HIV testing. Rapid HIV test kits were approved and available in the rest of the world before they were approved and available in the United States. Self-test kits for HIV were approved and available in the rest of the world before they were approved and available in the United States. So we adopted much more systems approach of opt-out HIV testing, offering the testing versus waiting for someone to ask for it. And we mimicked more of the partnerships, including newer, more partnerships in that we had been doing around the world. So yes, we continued with our wonderful Ryan White planning councils and community groups, but also formed a Places of Worship advisory group that brought in our churches and our active faith-based activities that were very pro-HIV responses. So we just brought more of the community in, but not in generic, general ways, in very focused ways, because we could give them a snapshot of their community members and what was needed. And to be able to bring that together in partnership to design some of the solutions that were there. So I think in that case, and I think the other part we appropriated from what we had been doing in PEPFAR is not just starting with the data, but then following the data. And if it wasn't working, we got to try something else because we didn't want people to be left behind. So it was actually how our work in Zimbabwe came and affected and sort of upgraded the DC response to get it caught up.
Oh, that's a really powerful story, and for the group, it's another reason why this class is global to local. We don't. The premise here isn't that there's the information and experience only goes one way. But thank you, Shannon. That's such a I've heard that so many times from people who've had, especially in the HIV space, have brought so much that they've learned to the United States. So let me switch to Becca, and that's so not Rebecca.
Yeah,
Becca,
yeah.
Becca Wright, I believe is
Thank
somewhere out
you.
there. Thank you.
Thank you. Yes, thank you so much for being here, Shannon. We've been discussing a bit about the role of community within public health and it being an absolutely crucial role in the health sphere, particularly in the success of health campaigns. But I want to dig deeper on your experiences with community connection regarding health campaigns versus in your political campaigns, and if you could describe the differences between the two or potentially the different roles they played, any information.
Yeah. Well, I feel I one of the privileges of my life, I think, is being an AIDS doc.
Mm,
Because the HIV response and how it evolved in this country, but also globally, is really grounded in, as I mentioned, nothing about us without us,
mm,
and community participation. And I would say that included some very formal ways or supported ways to ensure that community wasn't just engaged, but was part of the response, right? And so, we have, thank goodness, from the Ryan White Care Act, and some other public health congressional acts, actually funding was put into structures that could ensure that communities had a seat at the table. And being able to spend some money so that you can convene and give people seats at the table who are affected by the decisions being made at that table is really super important. And I think throughout the HIV response, whether it's local and that pattern, whether it's global, UNAIDS, follows this as well. We have evidence of how important it is for impact, but also it's the right things to do to have community-led organization, not just individuals, but community-led infrastructure and groups and coalitions and people. Part of, yes, being able to be direct service providers for the services that are needed, but also being at those decision-making and policy tables, and also being on the accountability side, community-led monitoring and evaluation to see if what's been promised is actually being delivered. And I think where we have provided funds to make sure that that can happen, that it's not just reliant on volunteerism, that it is an official part of some of the requirements, is when we've been really successful at building relationships over time, which really leads to trust. And I wouldn't say that means everybody gets along all the time, but it's really good to have a long haul community connection because you can disagree and you can work through really hard problems and decisions and try them out, and then you can make it better if it's not working. And I think that, agility and constancy is really where trust can come from too, because there's an honesty and transparency with it. I I guess it's not really ironic, but when I went to run for Congress, I was not looking forward to it necessarily. I'm a massive introvert, going and talking to people all day, every day. It's always been part of my public health job. But then when you're running the Congress and you have to talk about yourself also, which is so weird. I was not looking forward to it. But I found out really quickly it was actually just the same as HIV stakeholder work I've been doing my entire professional career. It was going to, whether it's local Democratic clubs, community events, churches, to talk to groups of people and to hear from them what's important, what they want, and what they need. And so I actually found the engagement to be completely identical in substance and in meeting and in practice, even if the structures of it are a little bit different. And I ended up having a blast running for Congress. That part, which I might have thought I was gonna like hate the most, I loved it, and it resonated with everything I've always done in the HIV response. And it was also a very luxurious way to go back to my hometown that I hadn't, been permanently living in since I was 16 years old and get to reconnect with not just all my friends from, kindergarten on, but to be able to pop into communities and quickly get to know them in ways that if I had just been Shannon moving home, they'd be like, who is this woman who has just walked into our room and why should I tell her anything? But if you're running for an office and you're trying to figure out what they need, people will tell you a lot. And so it was a really fantastic experience, I think, because I had been an AIDS doc.
Thank you so much for that.
Yeah.
I love that answer. Well, let's open up to the rest of the class if that's okay. I think the simplest way to do this, if you wouldn't mind, is just putting your hands up so that I can call on you one at a time. I don't know any good way to do this. So, Jessica, it looks like you've got. There's also one of those. You can do the
Hand
little
emoji.
yellow hand, the raise hand function. But Jessica, I saw your hand, so we'll start with yours. But please use the yellow raise hand function. It'll be easier for me to see you. But Jessica, please.
It was really cool to hear how expansive your experience has been in different industries. My question is, does service feel different as an AIDS doctor and as a policy director? I asked this because for me, I'm in the School of Foreign Service, but looking to go into nursing next spring, because I feel like I would be not very grounded if I entered little or big P politics without sort of a why, like that's bigger than myself. And I feel like I would find that like indirect like person-to-person service.
Yeah.
So I was sort of wondering your experience with that, like how it felt going from like serving
Yeah.
one person to like an organization serving like a mass of people.
Mhm. Yeah, what a great question. How do I answer this? I mean, I might back it up a little bit. So for me, I went to medical school because I really wanted to have some hands-on skills that translated across cultures or languages or anything else. And that was really important to me. It wasn't just sort of theoretical. I wanted to touch patients and work with patients and that. And because that was a passion, but I did it knowing that I wanted to do public health as my career. But I have to say, within the realm of public health, that is part of my distinctive comparative advantage, right? Is connecting that ability to connect that sort of frontline clinician's point of view with the bigger, policy or population level. And so I'm always reality testing. I call it like the bifocal point of view. Can you look up at the 20,000-foot strategy or program design level, but also look right in front of you? If you were the person in that hospital, would it make sense? And saying, how do we gel these so it works? That said, there are plenty of distinctive comparative advantages across whether it's public health or policy work. My friends who are economists get to bring that distinctive economist, economic analyst skill set to our multifaceted teams on this. So I think there are plenty of ways to build your expertise and your comparative advantage from non-clinical pathways, period. But if so for me, but if you have a drive that and a passion that says, I want these skills on the clinical side as well, I have zero regrets from my clinical background. I would go back and do it 10 times over. Which you hear a lot of grumpy old doctors who don't say that. They're like, oh, medicine these days, blah, blah, blah. I wouldn't. But I also don't suggest that it's the path for everyone. So I don't know if that helps or not. But if you're feeling a drive to do it and like you really want to do it and be in that role, even if you want to take that into other spaces, that's awesome and that's great. But I don't think anyone should feel like that there's only that path to being a sound policy person or a sound public health person because there's so many paths. Yeah.
Thank you.
Great answer. Thank you. I'm just going, I'm sure this isn't the order that the hands went up, but there's the order on my screen. So Lauren, do you want to?
Yes, thank you so much for coming. Something that I'd like to hear a little bit more about. You've worked all around the world, and I was curious if you could elaborate on how you navigated cultural differences. Were there moments you felt culture shock? How did you overcome that to continue to serve? And especially, how did you maintain cultural humility in the context of HIV/AIDS when there can be so much cultural stigma around it?
Yeah. What a great question. I think partly why I chose this track, and I think many of my colleagues do, is because I love and I seek out sort of that cultural connection, right? And being able to connect with different people in different places and explore that together. There is a real luxury of doing that in public health. I'm sure there's other ways too, public health, because as opposed to being a tourist, you're you're working directly with people of that community and of that country and who are leadership colleagues in the country. I mean, you're a visitor, you're a guest, you're a partner, and you have a luxury of working with massively dedicated, high level to ground level leaders in projects throughout, which I think you wouldn't necessarily get just by, going to travel someplace. And so I think, the luxury of, I mean, that's a, sort of second luxury in my life is the wonderful, amazing colleagues and now friends I have all over the world. And I think if you go with curiosity and, as you said, humility, Second, I'm always going there as a partner to, help my colleagues build what they need, you know, is part of it. I think second, you build relationships and trust through sweat equity. And if you are putting in the efforts, if you are willing to do a lot of work, if you are there not during just the successes, but also the hard times, if you are there helping to problem solve when things seem dire, then also people forgive you if you get things wrong from time to time, right? Because you have a real human connection, so you don't have to have perfection in all of that. And so, curiosity, humility, knowing your role, but also just, you know, not being a fly by night, knowing you're going to be there when to do the hard work, to get into the reality of what is and isn't working, what can and can't be there. As well as, part of that role can be sometimes your friends or partners need to be able to link on to what's happening in other countries as well, or in other communities as well, not just their own, as a way to push their own envelope internally. Sometimes it's easier than, someone at a local regional hospital saying, well, I just don't want to do it this way. I want to do it another way because I think it'll work better. Sometimes it gives them political cover to be like, oh, I heard 5 hospitals in Kenya were doing it this way. So why don't we try that? That they wouldn't have heard if you didn't have these sort of connections beyond your own borders. So there's also a community of practice that I think is what you're trying to build, where, we develop lifelong partnerships and friendships and professional relationships that transcend borders and cultures and don't require anyone to give up their own borders and cultures at the same time.
Thank you so much.
And I think you were particularly great at being a broker of those kinds of being thoughtful about when the opportunity comes up. So now we've got a queue. So let me let me go to Rebecca. Um,
Yeah, I'm just curious looking at your career path and seeing that you worked in so many different sectors of like public health, politics, and global health. From like your experience, was having that such a range of experiences an advantage when you were like navigating the job market versus like someone that really wants to specialize in one area? For in my case, global health. So yeah.
Mhm. Well, that's a good question. I think I'm not sure for any of our areas, even, I mean, global health is a huge area, right? I'm not sure that there's a linearity to any of these areas, especially these days. And so it's not that I planned to do this and then this and this and this. I think every time I was looking up to transitions, because I was ready for the next challenge or I'd finished up what I had planned to do, I just really went with an open mindset of, first of all, what is compelling as a mission that aligns with, sort of my service or passion orientation. And then second, what are the skills I can bring to the table to hopefully contribute, right? And that sounds simple, but it's not always. But for me, I had a very open exploration of that every time. And so I found opportunities that I wouldn't have necessarily looked for in that way because I wouldn't have even known that they were possible, right? Right before I was moving to Zimbabwe for the CDC Zimbabwe role, I was actually, out with one of my college roommates, and I'd gone to visit her in LA, and her husband had a little sailboat, so we were out on, the water right before I was moving to Zimbabwe in our like sweatshirts and drinking wine, and we're like, oh my gosh, if 16-year-old us could see us now, we'd think life turned out pretty darn great. Like never had occurred. Like I've been able to do things that were beyond my wildest dreams as a 16-year-old. And so I think the job market will always be fluid. The what matters at a given year might change in the dynamics of interviewing, but the reality is I think, and I've hired hundreds upon hundreds of people over my career too. So I've taken it from the other side of who am I looking for a hire. If you have, demonstrated dedication or passion or mission orientation, if you can show skills, and, examples of how you've applied those skills or how you've learned in a role and applied them, and you can show an openness to thinking about things, an agility of your thought, a willingness to explore and develop judgment. To me, those are the things that are much more important than have I always done one thing or have I done multiple things? I don't know what you think, John, but that's
No, no, I mean, as you all know from our first class, I I think that I really do believe in this idea that you got to keep, whether it's your head swiveling like in soccer or just keeping your head up when you're dribbling, don't look at the ball, look around you. I think it's very hard to predict in advance. It certainly has been in my life. And I'd say it's particularly the people I've worked with in global health. It is fluid and nonlinear. But so let me switch now to the Carolyn Maya combo to see who's got a question there.
I was just wondering, after your time both running for Congress and all of your unique roles working in leadership and with people in policy at the CDC and both overseas, I was wondering what some of your biggest challenges were that you experienced in bridging kind of that gap between healthcare and this people forward work and the leadership policy making aspect of it.
Oh, good question. Well, I think in terms of, CDC, and my wonderful, amazing colleagues and friends there, I think we still don't have a lot of people at CDC who have done a lot of policy work. So I think it's still an underdeveloped element across many public health practitioners, and that we should be looking at that more. Again, it's a little bit different if you're talking about healthcare policy. I think there's a much stronger part of the discipline of healthcare policy that's taught those schools, but I think a lot on the public health side still doesn't quite teach those skill sets with rigor. And so it's, being sad for my colleagues or figuring out how to work with my colleagues who this is still a little bit of a foreign language to them. That's a challenge. I think probably more importantly, it's a challenge, but I think it's part of the fun part and opportunities. And John knows I taught a course at AU this past term. It was called The Architecture of Influence, Advocacy Tools for Political and Human Impact. And I think the most important, the biggest challenge is helping people look for non-traditional partners to move a policy agenda forward. Now, some people will say, look 100% for your allies, and your friends and, work with them. And sometimes that might be the case. But I think it's way more exciting and sometimes effective, but it's very counterintuitive to many people to say, who are the people who I don't know, who aren't my friends necessarily, who might actually align on part of the what needs to be done, and then we can broker over the how it needs to be done, which we might not agree on. And I think looking for those strange bedfellows has been where breakthrough successes in policy often happen. The number of times that I have seen Nancy Pelosi and Lindsey Graham on the same stage as best friends for PEPFAR, you wouldn't believe, So I've seen it happen with my own eyes, and I would agree that we're in a very polarized environment right now. But I'm a true believer, and this can be hard sometimes, and it's hard to do, but it's harder to teach, to sort of, if you want to be really effective in policy, you got to suspend your judgment and you got to lean in with curiosity. You've got to explore people you don't know. and look for non-traditional partners who might, in fact, have an interest in the work you're trying to do. So I think it requires the most discipline. It requires the most sort of going intellectually and not just from your gut. And then it requires some judgment to say, okay, I've explored it all, not going there. Oh, I've explored it all, I am going there. But it also can be the absolutely most rewarding and most effective.
And I just note for everybody that the readings that you had for today included several pieces that Shannon had provided from that class, including the Bernice Johnson Reagan piece, the Emily Bass's piece. I mean, those are all one way or another stories about, not to mention Senator Frist's piece about different ways, at least in which you can think about partnering differently with different groups of people. I would just say the other thing in my experience is it's not necessarily it's not like you just wake up and say, oh, I'm going to find this new partner and tomorrow they're going to sign on to my whatever. Relationships matter. Trust matters. There'll be a point, especially if it's a really difficult new partner, somebody's going they have to believe that your word is good, that you will stick with it, because you're going to need the same from them. So figuring out how to build relationships, not when it's before you need them, not when you need them, is really important. So, amen to everything you said. And so, Katie, want to make sure we get every.
Yes, thank you, Dr. Hayter, for taking the time to speak with us today. I was wondering, for your work in managing the AIDS epidemic here in DC, I was wondering how you navigated the heavily stigmatized epidemic, given that it occurred in our capital, where we would assume to have a strong healthcare infrastructure. And then I'm also especially interested in how political pressures intersected with disparities across the wards due to different economic demographics.
Yeah. Boy, interesting. For our few minutes we have left, we could talk for an hour on this one too. So, stigma is real. And I think one of John and I's, long friends, Ron Baldessari, always made an analogy that, combating stigma is like gardening. You pull up the weeds, but they're going to keep coming back. So you just got to keep pulling up the weeds all the time. And so I think you can never assume that stigma is not there. But I think we did a few things that were really important, if not shocking. Part of the challenge we had in the district is at the time I said, we were set up to talk about and deliver services for a 1990s epidemic when it was, a 2010 epidemic. And so people's perceptions about who was affected, who wasn't affected, and what they needed, I don't think they were even grounded in the 90s. I think they're grounded in the 80s kind of thing. And the reality was that wasn't the epidemic at all. Right. And in fact, we had a multifaceted epidemic, every single risk group with, high rates. And believe it or not, despite the conventional wisdoms to the contrary, 7 out of 8 wards had high rates of HIV, high enough rates to be considered a generalized epidemic among adults. Which was not the perception. The perception is like, oh, it's just that ward 7 and 8. It's only poverty. We're a really small town, actually, and they're very unique and interesting communities and dynamics. But the reality is part of combating stigma was actually getting the real picture out of who was affected and that it was actually more people than people would have thought. So breaking down some of those stereotypes and perceptions. Second was actually oftentimes combating provider stigma is a heaviest lift. Even providers who think they're being generous in their approach. This is partly why we rolled out opt-out HIV testing. We rolled out a campaign that was ask for the test and offer the test, and we would have our own staff members when they saw their doctor would ask for an HIV test because it wasn't being offered. And more often than not, the provider's answer was like, why do you need one? Like with horror and, I wouldn't have projected that on you. It's like, this is a medical thing. So providers can be a challenge for stigma as well. But I think this is also where community leadership is really important because no matter what a health department says, no matter what a provider says, if people don't find support in their churches or their kitchen tables, if they're hiding all of that, then all of the programs in the world aren't going to help. So it's really multifaceted. We could talk for hours about the many different things we've done. It's still not a done deal, but it remains a problem. Yeah.
Well, I'm looking at the clock because we're getting near the end, and so I'm maybe with my apologies to Isabel, maybe next week we'll get you at the top of the list. I I guess I'd like to close a little bit with asking you to reflect on hope. I do think it's really the issues that we're talking about here in terms of shaping health and improving health and changing and hopefully letting people live longer, healthier lives is a perennial issue, no matter who's president, no matter what the larger geopolitical dynamics are. So I guess, Shannon, I'd ask you what advice would you have that gives you hope right now? What's the glass half full, the thing that I know we could spend hours talking about all the challenges and they are real and I don't want to minimize them. But what gives you hope? Because I do think we've got a group of young people here, younger people who really do want to make a difference and it can be hard.
I think what gives me hope, few things really, but I think, what gives me the most hope is I know it's possible to create a healthier world and healthier communities. Maybe this is a little bit of the grumpy old lady side coming out, but things that we take for granted now as just having been done and accomplished and being normative, like the entire global HIV response or even the domestic HIV response, it was never obvious. It was never easy. And, we used to actually talk about, we got to make the impossible possible when no one thought it was possible at all. And that's not overstating it, I don't think. And so having seen that happen and be accomplished, not just for HIV, but, I can graph it out from HIV, when most people thought it was impossible and didn't want it. And, massive stigma and massive lack of political will makes me know that our ability to achieve results is only limited by our imagination and our willingness to do the hard work and to persist on doing the hard work, even when it's not clear how quickly or how easily you'll get through it. So, the things that I've been privy of collaborating on throughout my professional lifetime, we get to see the headlines of success now, but none of them ever felt easy at all. And yet they've turned out better than my wildest imagination. And so I know for a fact, we didn't do international development because there was an organization called USAID. We don't care about global health just because you can major in it now. We and the collective we do these things because we know in our heart it matters and we care. We believe in the resourcefulness of being able to help and make progress. And we are living at a time of amazing creativity and innovation should we choose to use it. And it won't always be fast, but it also won't always be slow. If you know anything out of a policy environment, windows of opportunity suddenly open. And if you're prepared for them, boy, can things go suddenly very, very fast. But oftentimes they're built on a lot of slow work that's been done along the way. So I'm hopeful because all y'all are here. And all y'all are, spending your time developing your skills and your thinking and hopefully your vision on what roles you might play in the future. And I believe in design and I believe in impact, and I think we can get there.
Well, let me say thank you, Shannon, for joining us. Maybe a round of virtual applause, if I could, and thank you for your time. We are so grateful. Just a reminder to the group, hopefully we'll be meeting in person next week if there's not another snowstorm. And we've got Ndidi Nweli, who's going to join us from the One campaign and talk to us about what her thoughts are in this moment of transition. But I just again want to say we'll hopefully again see everyone next week. Just you see your readings and hopefully all the assignments in Canvas, so you're all ready. But Shannon, thank you again.
Yeah.
What a wonderful evening. Have a nice evening and say hi to all your friends.
All
Both
right.
of your
And yes,
friends
it is
there.
a Maine Coon, whoever guessed the right cat.
Yeah, somebody who is that? Oh, well done. Wow, that's very impressive cat knowledge on this call. So that's great. Anyway, thanks everyone.
All
Bye-bye.
right. Bye, everybody.
Thank you so much.
Thank you so much.